Thank you, Dave. Thank you very much for the invitation, and to the Scottish Drugs Forum for hosting the event. So I've come to present some examples or some of the situation from Norway. Not so much maybe for you only to learn from Norway. I'm here also to learn, and I think that's how it is. We can learn from each other, and situations with drug-related problems, they differ between countries, and I don't think that our solution in Norway necessarily is the right one in Scotland or other places, but I think we can learn elements from each other anyway. My primary focus in my research, because I come from the University of Oslo and I primarily do research, is on preventing overdose, and that will be part of what I'm talking about at least. Very briefly on Norway. You see it there in the color. We have a population of about 5.4 million. There's an estimate that there's about 10,000 opiate drug users in Norway, so that's less than it would be in Scotland. They are polydrug users, as here. Many of them would use benzodiazepines and other drugs. We've had traditionally high rates of injection, although that's changing a little bit actually. More heroin users are now inhaling, smoking heroin as well. We've implemented opioid maintenance therapy or methadone buprenorphine treatment to quite a large extent, and we see that fewer people in the treatment group are dying from overdoses and therefore also aging. But we also see a diversification of the opioid drug users, and increasingly the opioid drug users are now using prescription opioids and tablet-based opioids instead of heroin. In terms of what our beliefs, what do I believe and what do I think? I think that just to have stated it, that those who are addicted to drugs, including heroin, they are recruited among the pool who are drug users. And therefore, it is also in that context of the total consumption model that we know from alcohol research, that it is important to restrict, reduce the number of drug users as much as we can to reduce also the societal harm. Although we also need to apply, of course, treatment and harm reduction. And opioid agonist treatment, so like methadone and buprenorphine, is the primary treatment option and the gold standard for opioid addiction. And it's an evidence-based treatment, and those in need for the treatment should get the treatment. And I also think and that addiction is a chronic disease, and therefore the treatment needs to be long-term. It shouldn't stop after 2 years, after a certain period. Typically, many would need that treatment for a long time and sometimes lifelong. When I grew up on a farm in Norway, a grain farm with barley and oats and stuff, and then there were 2 seasons. There were the planting seasons or the seeding season in May, and then harvesting in August, September, so about 100 days later. And there were distinct seasons and activities, and they had distinct machineries. And to some extent, you got what you deserved. If you did a good job in spring, you could harvest well in the fall. So why am I talking about farming? Well, because I think drug policy and our field has some of those elements as well. But if we use it as an analogy, I think drug policy includes both those seasons at the same time and all the time. So we're both planting and harvesting at the same time, and that's quite difficult and a challenge. And that's why it's not easy to be a policymaker or decision maker in this field. And as Roy, I think, said this morning, he pointed back at some of our international politicians in the 80s or 90s, Thatcher and Reagan. And actually, I do think that those who are in position today, they need actually to deal with decisions that were made and taken a long time back. Even just becoming someone with the disease, opiate addiction, it takes a time. Maybe they started taking drugs when they were 15. We see them the first time in treatment services when they're 35, so 20 years later. So it takes time to develop. So some of the things that were decided and done and practiced in the societies 20 years ago, we are experiencing the results from that today. And we have to deal with it today. And then also drug taking and drug use today certainly results in acute situation, intoxications and drug use and crises that are there and current. But they are partly a result of what started a long time ago. And then practicing drug policy today is also what another minister probably is going to harvest from 20 years ahead. And we have to take that responsibility as well. So I think this duty is quite difficult and challenging actually. And the current duty, in my view, is about providing both prevention and strategies to reduce the number and the burden in the future and deal with the current problems. Some of them, in a way, self-inflicted and others actually inherited from someone that was there before. And we have to try and balance all these things together and at the same time. So sometimes I talk in the Nordic region, and I made this slide with the the Nordic countries, and then I was invited to talk in Ireland, in Dublin, about a year ago, and then I added Dublin, and now I'm here, so I added Scotland. And just to show that in the Nordic region, Sweden is kind of the big brother in terms of population, while the other countries are 5-point-something billion people, and so seem Ireland and Scotland to be as well when I looked it up at Google the other day. And then we do have similarities, but also certainly differences. And in terms of overdose deaths and that burden, Norway has been among those countries with high levels of overdose death rates, and we still are. But Scotland is on a challenging situation right now, as you're aware of. Norway in the Nordics have been the champions in the application of OMT, so methadone buprenorphine treatment, with high rates. 8,200 today, out of those maybe 10,000 in need of the treatment. So a high treatment coverage rates of maybe 80%, which I think is one of the keys why our problem hasn't increased in recent years. So a high treatment coverage is important. Tim Miller and Andy McCauley, they did some work for EMCDDA some years back that involved the Nordic countries and also Scotland, and they looked at who are the at-risk population and how is that related to opioid or overdose deaths. And they made estimates that the target population and the number of deaths, they have some sort of a link, and they do come on a fairly straight line, as you see. So when Scotland experiences high number of overdose deaths, it's also because there's a high number of drug users, of opiate drug use, and maybe not enough people in opiate maintenance treatment of good quality. So that may be one of the challenges that's still remaining. Because in European reports, this picture came out a couple of years ago. Scotland all of a sudden appeared on its own, not as part of the UK. And then, as you know and as you've seen over the past years, overdose deaths have increased and rapidly, and in European context to be the most dramatic. But also, what Sackett showed, it seems maybe to have plateaued and turning the right way with the most recent numbers, which is good. But if you see that Norway is a pink line, and to the far, what is it, left, I think, in the picture, when that picture started in 2000, Norway was that country with the highest European levels of overdoses. And then it had a decrease until 2003, and then since it's been fairly stable, so the number or has been fairly stable. But we're part of that colorful spaghetti with several other European countries. We can see that the dark blue Estonia had a peak when they had a fentanyl outbreak, and then it turned back again. And in recent years, Sweden has had a peak, and it's also turned back again. But Scotland, in this picture, until 2018, hadn't turned yet. But I think some of these patterns and trends, they come and go, almost no matter what we do. You can be unlucky to be on duty when a dramatic event happens. But then also you have to deal with it in the best way you can. And attending another conference, I got this picture from a colleague from the US who had put together some different European countries and the US and Canada. And when we read about the opiate epidemic and the opiate crisis, we often think of the US, and as you see, Scotland has been up at those levels. And then Canada is third, and then many other European countries, such as Sweden and Norway, is in that group, around 70, 80 overdoses per million. So what are the recent concerns in Norway then, having put this some way into a context? First of all, these are our overdose numbers a little bit more in detail over some time. And we had our peak around 2000 when we were on the top on the European level. And then since 2003 until today, it's been a fairly stable or flat line, actually. In Norway, that has been used as an argument that everything we do in terms of drug policy and exercises is not working. Look at the numbers, they're not changing, they're not going down, so whatever we do, it's not working. So that's one way of looking at it. I don't think it's right. I think it's a simplification. And I'll take you through a little bit of the explanation at least. And only the two most recent years, in 2020, we had 324 overdose deaths, which was the highest in nearly 20 years. And that was made the newspaper headlines. And then the year after, we were at 241, so the lowest in 13 years. And we see that these numbers, they change a little bit year by year, maybe even without being a sign of a major change. It's just a fairly stable annual count for the country. So I say that because this is another way of looking at it, where the dotted green lines around the red line is some sort of a confidence interval. So with the Norwegian numbers during the past years, to say that it's really a change, a difference, it should break properly out of the green lines. And even the two most recent measures haven't really, they've been around the outer bounds, but one high and then one very low. And therefore, I expect this year, which will come this 8th of June, our next year numbers for 2022, to be somewhere more in the middle than the two extremes we've seen the past couple of years, which means an increase from last year until this year again. If not any other major change than what has been the case. But this flat line, what is it? Is nothing changing? Is nothing happening? Is nothing working? Well, if we look into the details and below the surface, we see again on the left side of this picture, the light gray line is heroin-related deaths. And from 2000 and until 2018 on that picture, heroin-related deaths have gone down from 250 a year to 50 a year. So that's 1/5, and that's a great achievement if you're interested in heroin deaths. They've really, in a way, disappeared as a problem. So many things may have worked if the target has been heroin-related deaths. That has been a huge implementation of methadone and buprenorphine treatment. It's been harm reduction with naloxone, many other things. So a lot of interventions targeted at heroin-related deaths. It seems to have been successful. But then applying methadone and buprenorphine as treatment, it results in some side effects. And in the right side of the picture, the darkest black line there and the light gray line is methadone black and buprenorphine gray. So they increase if it's applied in larger numbers. There will be some more side effects from that and some more deaths from the OAT treatment provision. And then again, this colorful spaghetti is a mixture of prescription opioids and the kind tablet-based opioid prescription, oxycodone, tramadol, codeine, etc. And they, in sum, are now the largest contributor to overdose deaths. So more than half of overdose deaths are from pill-based opioid treatments. And then a third or something from opioid maintenance treatments, medications, and a relatively few deaths from heroin. So there's been a change and a shift, and we need to see and understand this in order to make appropriate interventions. So what we've seen really is this, that the heroin problem has decreased significantly, while the pill and prescription opioids problem has increased gradually, and the observed trend has been this more or less flat line. But then you see that the heroin problem, it will soon reach the floor. It cannot decrease any further, really. And if the pill-based problem continues to increase as it's done over time, then we will see an increase again. And why has this pill problem increased? Because we've increased prescription quite greatly over the past years. We've liberalized the access to opioid pills, particularly for the treatment of chronic pain. So before, pain specialists only could prescribe opioids for chronic pain. Some time back, GPs could also do it. Some time back, you had to pay for opioid pills if you were treated with them. But when it's now a treatment for a chronic condition, it's reimbursed, so it's for free. So in different ways, it's a liberalization and an easier access to pills for free, in a way, for those with chronic pain. So the access in the society has increased, and then the problem burden has increased. So what have we done? What are the responses? What are the initiatives that's been taken in Norway? First of all, we were late in introducing OAT or OMT. Only in 1998 it was introduced. Before that, methadone was banned. But since, we've had a fairly rapid expansion. Now there's 8,200 in treatment in total. Both methadone and buprenorphine, 20% of them nearly are in the depot injections with buprenorphine. So we had quite a rapid expansion of the treatment provision to the target population, which is estimated to be about 10,000 people. And after 1 year in treatment, about 80% are still in treatment. So also the quality of the treatment seems to be fairly good. There's a high-dose treatment, people stay in treatment, and some are prescribed benzos while in treatment. Maybe 30% are prescribed benzos while they're in treatment. Yes, so the treatment is perceived as relevant for the target group. They approach it and they stay in the treatment. That's important, I think, and one of the key factors. Looking at some international comparisons, again from an EU report again, I think so the two dimensions in this picture, at the bottom axis, the x-axis, there is the number of people in opioid agonist treatment as a fraction of the target population. So 1 is everyone is in treatment, and 0.5 is half are in treatment. And on the other axis, the y-axis, there's the number of clean syringes distributed to injecting drug users. And if you're an active injecting drug user 1 year outside of treatment, I would think you need 1,000 needles a year, 3 each day. The WHO targets are that you should distribute at least 200 clean syringes to a injecting drug user a year. That's a goal. At least you should be there. That's the one line. And the other one, they suggest that you should have at least 40% of your target population for OAT in treatment. I think we can do better in both dimensions. And we should be high as Luxembourg on the access to clean needles, and as high as Spain and France in the access to OAT. So if it's possible for some countries to have 80-90% of your treatment population in OAT, then the rest of us should try that as well. So for Norway, I think we can still be better because other countries have performed better, but we're also not doing all that bad compared to other countries. So we're both giving access to harm reduction and clean needles as an example, and the provision of formal treatment, which is of a fairly good quality for most of those in need. But when we have new populations with overdose risk, then we need to tailor the interventions to meet their needs. But we cannot forget those ones that were there from before. So we need to continue to provide treatment for those with heroin addiction. They seem to be effective, and they should be applied continuously. And for example, we have a national overdose prevention strategy where the provision of OAT to as many as possible is one of the strategies. But also we need to make sure that OAT works well and that it doesn't cause more harm than benefit. So there needs to be some way of trying to keep the methadone and buprenorphine-related overdose deaths low. That's important as well. And if you have new types of opioid users, those who primarily use pain prescriptions, then that also needs to be addressed, maybe primarily towards the GPs, those who prescribe them, education towards them, and making non-opioid treatments available, for example. So again, interventions need to be targeted towards the problem that you actually have. And if you have a range of problems, you need a range of interventions. Towards the chronic pain issue, which is now our main issue in Norway, it seems we need to improve the training among prescribers, and particularly on non-opioid treatments, which are the best ones and preferred ones, although not always the most easy to apply when you have a patient sitting across the table and reporting pain. But revise clinical guidelines for the treatment of chronic pain, and maybe again restrict and reduce on opioid toward that treatment group. Opiates aren't particularly good if you are to take them every day, every year. They're good if you break a rib or sprain your ankle to use for 10 days, but not for 10 years. And again, make non-opioid treatments available, like physiotherapy and cognitive therapy and other things. The interventions more overall on a country level has been that I'm going in for landing soon now here in terms of time. Norway has, since 2014, had a national overdose prevention strategy. It includes governmental funding for it, for the interventions included in the plan. It includes an naloxone distribution program, not as big as yours, but still a fairly big and fairly successful program, and also access to low-threshold ORT. The Norwegian system were previously termed as a high-threshold system. It isn't anymore. We do have 2 drug consumption rooms. We do have injectable diamorphine or heroin-assisted treatment in 2 clinics in Oslo and Bergen. And the strategy also comes with funding for research to monitor and continue to understand what's going on and which interventions work or not. And the latter, I think, is really important, not only because I'm a researcher, but if we are to learn and understand what's working and not, we need to monitor and evaluate it. So my recommendations to end is that we need ongoing local evaluation and research, and then adapt our interventions to the local situation, which changes with time. It needs to be a long-term, coherent public health policy, and it shouldn't change every time the government changes, or it's better if we have 10 years and 20 years of perspectives. We need the provision of a range of services because the needs differ between different people and at different times of a addictive disorder. Adequate and stable funding, so that shouldn't fluctuate and change. And again, provision also of harm reduction services and user involvement, both in development of policies and clinical interventions. And for overdoses and for many other drug policy-related issues, it is a moving target, and we need to follow. If we design something that we think is the absolute right thing right now, it may not be in 2 or 5 years, and we need to monitor and follow that.